Fast people, hold on tight. It's time for another exciting episode of Optimal Anesthesia, and this time we're stepping on the gas to delve into the exciting realm of regional anesthesia for children. You might think of this as a high-octane tour of the field of pediatric pain treatment. Ready? What are we waiting for? We'll begin with the foundation of our understanding, the anatomy. In neonates and infants, the spinal cord and its meninges have their own unique journey. At birth, the tip of the spinal cord resides at L3, but by their first birthday, it's made its way up to L1-2. And don't forget the meninges, they start at S3 at birth and reach S4-5 by year 1. It's like a growth spurt happening within their tiny spinal columns. Imagine the precision required when administering regional blocks in these little patients. The stakes are high, and accuracy is key. Moving on to CSF, infants and kids weighing less than 15 kilograms have a higher volume of cerebrospinal fluid compared to adults. Indeed, they have about 4 milliliters of CSF per kilogram of body weight, while adults have only 2 milliliters per kilogram. Now, why is this crucial? Because it affects how local anesthetics are distributed within the central nervous system. Dosage calculations become an art in this context. Now, picture the epidural space. In infants, it's not the same as in adults. Instead of the mature, densely packed fat lobules, they have spongy, gelatinous lobules with distinct spaces. This difference actually helps the wide longitudinal spread of injected solutions, providing unique challenges and opportunities in regional anesthesia. Now let's switch gears to the physiology of it all. Myelination, for example, plays a significant role. Myelination starts early in cervical neuromeres during fetal development and continues throughout childhood. This means smaller fiber diameters, thinner myelin sheets, and shorter internodal distances in infants. Hence, they require lower concentrations of local anesthetics for nerve blocks. So, in simple terms, you have to be extra careful with the dosage to prevent toxicity in these tiny nerves. Let's not forget the heart. Surprisingly, pediatric patients exhibit lower rates of significant hypotension in bradycardia following spinal or epidural anesthesia compared to adults. It's like they have a natural shield against these side effects, which is a remarkable difference when considering the use of regional anesthesia. Alright, rev your engines. Picture this. Pediatric regional anesthesia is like giving our little patients a smooth ride through medical procedures, keeping pain at bay while steering clear of pesky side effects. Think of it as the superhero cape of medicine. It targets specific pain areas, leaving the rest of the body untouched. We're sparing our young heroes from complications and ensuring speedy recoveries. It's a finely tuned machine with various tools and techniques, like choosing the perfect race car for every track. Time to introduce our star players, the amide local anesthetics. These aren't just any drugs, they're the secret sauce in our medical recipe. And we've got some awesome doses for you. First up, 2-chloroprocaine, a speedster with a 2% or 3% concentration, giving short but effective relief. Or how about lidocaine, a real quick fix at 0.5 to 2%. Then, there's bupivacaine, the long-haul trucker at 0.1 to 0.5%, perfect for a lengthy mission. And we've got a lot more in our pit crew. Time to peek under the hood and see what makes these engines roar. Let's dive into the science behind the magic. Imagine our little patients' bodies as high-tech race cars. These amide local anesthetics are like the master mechanics working on the circuits, nerves. They block pain signals dynamically. The faster the signal, the harder they hit the brakes. It's like a Formula One race. Every hero needs sidekicks, and in pediatric anesthesia, we've got adjuvants. These are the turbo boosters for our anesthesia vehicles. In our arsenal, we've got morphine at 30 to 50 μg/kg, fentanyl at 1 to 2 μg/kg, sufentanil at 0.5 to 0.75 μg/kg, clonidine at 1 to 2 μg/kg, dexmedetomidine at 1 to 2 μg/kg, and even ketamine at 0.25 to 0.5 milligrams. These guys team up with our heroes for prolonged pain relief. It's like putting on the afterburners to zoom past pain. But remember, even the fastest cars have to navigate curves. Pediatric anesthesia has its twists and turns. It's all about safety. Sometimes we have to watch out for systemic toxicity, where too much fuel can lead to trouble. We've got our trusty intralipid that can swoop in like airbags, deploying when things get dicey. Safety first. It's time for the grand finale. Pediatric regional anesthesia isn't just a medical procedure, it's an adrenaline-pumping adventure that guides our little heroes to a pain-free victory. That's a checkered flag for this episode of Optimal Anesthesia. Don't forget to hit that subscribe button to keep exploring the fascinating universe of medicine with us. Until next time, stay curious.